A thought I have also is that can really prognosis be determined at baseline, or do you need to give a few cycles of therapy and see what happens? Like MRD has been found to be a very strong prognostic marker. Of course, there are outliers. You can reach MRD and you can bounce back again. But if you reach MRD, that tells you that the disease also is responding to treatment. What do you think about that?
I think there's, this is another very important point, which is, well, two topics I think to mention is one is that it's not just the depth of response, it's durability, right? So high-risk patients can get deep responses. It's the sustaining and the durability that's important. And I think one of the challenges of MRD testing is, in clinical trials, it's been very reproducible and helpful. But in real world, when was the last time you had a community physician who did a serum immunofixation test? And if you don't do that and it was positive, this patient, whatever the marrow shows, is not an astringent complete remission MRD negative, right? So I think there's some caveats that we should put on that. But high-risk patients maintain MRD negativity, but if they don't sustain it, that's the problem. And then I think the other challenge to talk about with risk, and this isn't true of myeloma alone, is we have to distinguish between therapies that are improving high risk and those that are overcoming high risk. I think a lot of agents, we've had so many drug approvals in the last decade in myeloma, and every drug has improved high risk, but none of them have overcome high risk. And so I think that's the real challenge, is to talk about these both with physicians in the community as well as patients about what to expect for high-risk patients with these endpoints.
Actually, that's a really important point you make, because just in our previous discussion about, okay, if we were going to use quads or add in Dera, and I think the one place where I'm not seeing Dera really push the envelope is high risk. I know that all of these have been subgroup analyses. Maybe in the Halcyon trial, there was a better subgroup outcome for high-risk patients, but in Maya, there wasn't. And some of the earlier data that's coming out of these quad trials, we don't know that high risk is being overcome. And so that might be a situation where if you were really thinking about it, if you had a KRD versus a Dera VTD, something like that, you might choose a KRD over that. That's completely hand-waving and not evidence-based.
But I think I'm going to challenge that, because I think if you look at every study in phase 3, and first of all, people want to talk about risk and drugs in phase 2 studies, which is not appropriate. You need all 4 groups represented. You need standard risk, high risk with both novel and conventional therapy. And you need all 4 of those Kaplan-Meier curves on the same graph to determine what's going on.
Yes.
And the problem is with carfilzomib, in the Endeavor study, it did not do any better. Those high-risk patients still did worse. And I think one of the challenges with the Dera is we look at these forest plots that look like high risk doesn't do as well, but that's different from the Kaplan-Meier curves. These patients with high risk are still doing better with the addition of Dera. They may not be doing as well as standard risk, which is definitely true, but I think that's a misinterpretation of the data. No one is being harmed with Dera.
No, I don't
They're
think
just not being overcome.
I don't think
right?
it's being harmed. Should you choose something else? Is there another study where...
Well, CAR-T, that would be a great.
Yeah.
But I think with our current arsenal, no drug has overcome high risk.
No, I don't think
Right.
any drug.
So-
maybe a combination, if you believe this University of Chicago data also that you're getting equal outcomes for high-risk patients, but small numbers. I don't know.
I agree with you, Ajay, that in the true high risk, none of the drugs have been able to overcome that. But I think there is some evidence, I do think, still of improvement. If you look at the number of patients that fare poorly clinically, we all agree that these markers are not optimal. So if I think in my clinic, say 10 years ago, how many patients had a poor outcome? I would think it's maybe 30–40% of the patients, like numerically. But today, with the newer combinations, including the quads, or if you use KRD or KRD Dera on trials, I think in my hands that group of patients that have a poor outcome is a shrinking species. So I think there is some improvement that we are overcoming. I'm not really sure where to put the finger, but something is happening in the right direction.
We're improving, but not overcoming.
Right.
Because those patients are still doing worse than standard risk patients, right?
But
That's the point.
but they are
Move the
doing,
curve
there
for
are
everybody.
fewer of them, but the ones that still fare poorly on the best drugs we have today compared to the best we have a few years ago, those patients really do poorly. So we're kind of starting to enrich a group of patients that have a very aggressive
But the fact is those
biology.
patients may not even been alive in the past, right?
Yeah.
Could be.
That's
possible.
We've never had flat OS curves.
No, of course not. I mean, that's
So-
why there's always something to be developed in myeloma.
Yeah.